Good morning. This is Stephen Holloway. This is Nursing 211. Today we'll be talking about invasive hemodynamic monitoring. The objectives for this lecture include identifying the purpose of hemodynamic monitoring, identifying the indications for hemodynamic monitoring, and then identifying the components of pulmonary artery Gans catheters, or a Swan Gans catheter, or you may just hear it called a Swan line. Other objectives that we're going to try to meet is to identify the correct pressure waveforms for each of these components of the hemodynamic monitoring, identify the different components of the invasive hemodynamic monitoring, such as CVP, central venous pressure, pulmonary artery pressure, both systolic and diastolic, pulmonary artery mean pressures, and the pulmonary capillary wedge pressure, or you may just hear it called wedge pressure, and the systemic arterial blood pressure. Your goal is to identify the normal parameters for each of these components of the monitoring. Terms that you need to be familiar with if you're not already familiar with include preload, afterload, cardiac output, cardiac index, central venous pressure, CVP, pulmonary artery pressure, or PAP. Pulmonary artery pressure is measured as systolic, diastolic, and mean pressures. Pulmonary capillary wedge pressure, or PCWP. We will discuss most of these as we go through this lecture. Other terminology: phlebostatic axis, mixed venous oxygenation. You'll see it designated as SVO2. You need to understand what a transducer is. You need to be able to identify the distal and proximal ports of the Swan-Ganz line. A cordis or an introducer is part of the process. Then you'll need to understand systemic vascular resistance and pulmonary vascular resistance. Let's start out by talking about systemic arterial pressure monitoring, or an arterial line. Many of you will see these in all of the ICU settings you go to. It is for measuring systemic blood pressure. It gives us a real-time reading of the patient's blood pressure. Normally, it's done via a catheter placed in the radial artery. Now, it can be placed in other arteries such as brachial or femoral, but there are much greater risks that go along with the insertion in these sites. Indications for an ART line or an arterial line is if we have someone we need to continuously monitor their blood pressure. We need very accurate monitoring of their blood pressure, especially for disease processes such as shock, or we're giving them vasoactive drugs, such as you did on your module assignment, or they're in hypertensive crisis. Another reason we'll do it many times is frequent blood draws. If someone's on the ventilator and we're having to continuously monitor their arterial blood gases, this is a great way to draw the blood gases without having to stick the patient continuously with a needle. Some of the contraindications for the ART line are peripheral vascular disease or peripheral artery disease, hemodynamic disorders. The patients on anticoagulants will want to actually make sure that they're off the anticoagulants if possible when we put in an ART line. The use of thrombolytics, such as we talked about with MI patients and also with stroke patients. Other contraindications, especially at the insertion site, include that there's an area of active infection where you want to put the catheter. The last thing you want to do is introduce any type of infection directly into the arterial system. If the person has an area of a synthetic graft in the area, or sites of prior vascular surgery, with the coronary artery bypass graft, they're now beginning to use radial arteries as one of the conduits for that. So you would not want to put an ART line where that has been removed in the past. Systemic arterial pressure monitoring, basically the nursing care of the patient with an ART line. For most of us is going to be, number one, dressings after the insertion. So once the nurse anesthesia or the physician has placed the ART line in place, many times we'll be tasked with making sure we get a dressing in place. We want to immobilize the site, so especially in the radial, because as the wrist moves, it can vary the blood pressure. So we'll want to do that. we want to frequently monitor the site. We're looking at the site for any signs of bleeding, any signs of infection, and we're also monitoring for circulation distal to where the line is inserted. If like most patients you're going to see, it's going to be a radial insertion. You want to check the circulation distal to that radial site. So here's a look at a typical systemic arterial pressure monitoring or an A-line system. As you look at the site itself, here's actual the needle inserting into the radial artery. You can see that they have a clear drainage or clear dressing over the site. You want to be able to see the insertion site. Most of the time you'll see the nurses actually kind of wrap the tubing under the thumb and come back out with it. That's just so that there's no direct pull on the tubing itself. Most time the tubing is secured not only before but also after the stopcock. The stopcock is where we're going to draw the blood from. The stopcock is a three-way stopcock, and this is actually again where we're going to draw the blood from for this patient. You'll also notice that they have some type of some sort of brace around the wrist. There's different types of supports that you can put on there to keep the wrist in an anatomical position. It also prevents the flexing of the wrist, which basically immobilizes that joint so that you get a good reading from it. Now it needs to be padded so that we're not getting any skin breakdown. You need to check it frequently and watch it for those any kind of problems of skin breakdown. Now you always want to be able to see the distal extremities here so that you're looking for any signs of decreased circulation. You want to check the warmth, the capillary refill, the nail beds, all of that you need to check. So this is the part of the arterial line, as you can see. It consists of a catheter, tubing, a three-way stopcock, and then this tubing goes back up to the transducer, which then connects to the monitoring system. So it's pretty easy, pretty straightforward. Our job as nurses are to monitor this site, to check the waveforms, to make sure we're getting a good waveform so that we know it's functioning correctly, to make sure the dressing's dry and intact, to make sure the stopcock is turned off properly, and then to check the neurovascular status of this patient's hand distal to the site. Those are the main things that we will be doing as nurses. Now, the rest of any type of pressure monitoring system consists of a transducer. This transducer is basically a device that converts mechanical energy, basically the pulsations coming through the arterial line, the pressures coming through this line, into a signal that is then sent through a cable up to your monitor up here so that we can see the waveforms going across so that we can tell how well that's functioning. The other portion that we're going to look at is basically a pressure bag. Now this pressure bag typically is normal saline, and it's a bag of normal saline, can be 250, 500, 1,000, depends on what the policies are at the institution you're working. This is a flush solution. This is actually to keep this line patent. It's very similar to when we used to do saline locks, but basically it's keeping that line open. This has to be pumped up. This is a pressure bag, and this needs to be pumped up to 300 millimeters of mercury. I don't write real well with the mouse, but anyway, so 300 millimeters, okay? This basically keeps this flowing freely. If we didn't have this pressurized bag, what would happen is we would get blood coming back out of the site, coming back up the tubing. So we want to make sure that we're actually keeping that pressurized. Some will have a dial like this. Others will have a little device that kind of hangs down. and it actually will come out and will have little markings on it, and it'll tell you what the pressure is in the line. So it depends on which one you're looking at. But our responsibility as nurses is to make sure this never runs out of fluid, that we don't get air into the system, that we maintain it at the proper pressure. Those are our things. Now we'll talk about a little bit later with these transducers. With transducers, we have to level them, we have to zero them, and when we set them up, we have to make sure there's no air in the lines. Now, you may hear some people talk about a pigtail. Most of the transducers have a little device, some sort of device, where you can actually open it up and allow this to freely flow fluid from the bag into the site here. That normally occurs if we have to draw blood or if we need to flush blood back through the system. So you may hear someone talk about a pigtail. Most of the times you're going to have an extra stopcock. It'll either be at the bottom or the top of the transducer, depending on what system you're looking at, what system you're working with. But again, as nurses, this is the whole system when we look at it. A pressurized bag, a transducer, and then a catheter of some type that's delivering pressure back to the transducer, and then the monitoring system that it's plugged into. You can see here, this is a picture of a transducer. This is what I was talking about when I talked about a pigtail. This is just a little rubber type process, and if you want to open, it's connected to a valve. If you want to open it, you just basically pull this out, and actually you open the valve and allow fluid to flow freely through there. When you're actually working with a patient that has multiple pressure, hemodynamic pressure sites, they're labeled. Typically red here means arterial. Okay. Blue here is CVP, and yellow is typically the PA site. I'm sorry that didn't change colors, but that's okay. It's PA. Now you also from that site you can do the wedge pressure, and we'll talk about that a little bit later. I wish I had a better pen. But these are the transducers. You can see on the picture on the other one, the stopcock was at the bottom. Here the stopcock is at the top. These are all very important. You want to make sure that this is open through the system. The stopcock on most of them should be turned to one side or the other so that this is a free-flowing system. The only time you're going to change this stopcock is when you're actually zeroing the system, and you'll open it up to atmospheric air at that time. Okay. Now, when we have a patient that has an arterial line in place, we're going to see a numeric representation of the blood pressure on the monitor, and then we're going to see a waveform. The waveform is important so that we can tell how well we're getting readings back from that arterial line. The arterial waveform should basically have a very swift upward movement, kind of peak, come back down, and have a little bit of an arch here called the diacritic notch. You can see it a little bit better here, and that's just closing the valves. Basically, and what can happen is if you've got not getting the wrist is crinked and it's clamping on time, you can see these dampening, the sides will go down. You can see problems. Again, I don't expect you to look at a waveform and know that. I want you to know that it's important to monitor that waveform, because that can tell you many times whether you're getting an accurate reading with your art line. Now, it never hurts to actually occasionally get a peripheral or a non-invasive blood pressure just to compare the two. Typically, your arterial pressure is going to be a little bit higher because you're getting a direct reading. You can see old monitors used to have, and all the new monitors as well, will have the EKG, and then we'll have the waveform for the art line down below it. You can see that basically here's your QRS, this is your electrical energy, and then you can see on the monitor the mechanical pumping comes just a little bit later. Remember, we talked about this only represents electrical activity, does not represent mechanical. So you're seeing the electrical and then how it transfers into the mechanical activity of the heart. So you want to look, there should be a nice rise, a nice kind of a peak, back down, the diacritic notch, then slope down, back up. So it should look pretty much that way all the way through. So systolic is basically measured at the top. In used to, you can see this is actually has numbers on the paper. You could actually, if you didn't have a readout, you could kind of come here and you could kind of go across and see what the pressure was. So the systolic pressure on this patient is somewhere around, that's about 110 or so. So that's another way to look at the blood pressure. Fortunately, you don't have to do that. It's all on the monitoring system now. Now, A-lines are wonderful. Gives us a good reading on the blood pressure, gives us a great port to draw blood from, really helps us manage medications and many different things for the patients. But like most things, you have bad that comes along with a good. So there are complications from an arterial line. Some of the biggest complications can be thrombosis. You can actually have a clot form around that site and actually block off the circulation distal from the catheter. You can have blood loss. I have seen one of the stopcocks turned the wrong way and actually patient losing blood because the nurse did not turn the stopcock properly. You can get an air embolism or a thromboembolism. An air embolism is when, again, a stopcock is not turned correctly and you allow air into the system. Also, if you let the pressure bag go empty, you can get an air embolism from that. Systemic infection, again, you can get that because we're going directly into the arterial site. That's always a complication. You can see arterial spasms, rare but can happen, and again, that's where you would see changes in your blood pressure and you would see the waveform change. You can get a hematoma from the site itself because blood's leaking around it. You're going to see that more as you take out the arterial line if you don't hold good pressure on the site. You need to hold pressure on, when you take out an arterial line, at least 5 minutes. And when I say hold pressure, that doesn't mean put a little pressure on for a minute and look at it. That means hold very tight pressure to that site for the full 5 minutes. If they are on anticoagulants, you may need to actually hold pressure a little bit longer. And then you can get inaccurate pressure readings. And if we're managing medications based on those readings, we can run into complications from that. But again, that's why as a nurse, you're not just looking at the numbers, you're looking at your patient, you're looking at your waveforms to ensure that you have a good waveform, that your readings are accurate for that patient. Let's move from the arterial line to the Swan-Ganz pulmonary artery catheter. This catheter was introduced by physician Swan and Ganz in the early 70s. It was initially developed for the management of acute myocardial infarction. It's designed to actually measure the pressures within the heart indirectly, but it's not used for that as much anymore because it really didn't do what they initially hoped it would do. There were more complications from the catheter than it gave us good information in managing a heart patient. Now, almost any patient that has an MI will not have a Swan-Ganz. So it really only, most places that you're going to see a Swan-Ganz or a pulmonary artery catheter is in post-heart surgery, maybe someplace like in medical ICU or a surgical trauma ICU where we're having to manage multiple pressor agents on those patients, or in severe burn patients where we're having, again, to manage fluid shifts. And so those can help us manage those types of patients. Now, just like everything else, there's good and bad that goes on with these systems. So indications now for hemodynamic monitoring Any deficit or loss of cardiac function, such as acute MI, CHF, or cardiomyopathy, again, not used for that as frequently as it used to. Can be used in any type of shock, whether it be cardiogenic, neurogenic, or anaphylactic, but again, depends on the severity of the patient. You can use it when you've got patients with decreased urine output from dehydration, hemorrhage, GI bleeds, burns, or surgery. Again, typically not the type of patient you're going to see, but those can be indications for using this monitoring system. So why do we use it? It helps in the early detection, identification, and treatment of life-threatening conditions such as heart failure and cardiac tamponade. It's used to evaluate the patient's immediate response to treatment such as vasopressive or vasodilating drugs, and to look at mechanical support of the heart, especially if we're doing something like a intra-aortic balloon pump, or we're using some other type of ventricular assist device to actually help manage the patient's heart failure. It's also used to evaluate the effectiveness of cardiovascular function such as cardiac output and cardiac index. Was for years this is the only real way to get a good cardiac output without going to the cath lab. There are new systems using the arterial line where we can get a good calculated cardiac output based on flow rates through that arterial line. So many times these patients will not need a swan. We can just do an art line to get good cardiac if all we're looking for is cardiac output and cardiac index. Values that we can obtain from the pulmonary artery catheter include central venous pressure, or CVP, which is really a measurement of the right atrial pressure, pulmonary artery pressure, pulmonary artery capillary wedge pressure, also cardiac output, and the mixed venous oxygenation. All of those we can obtain through the pulmonary artery catheter. Now remember, cardiac output is stroke volume times heart rate. Normal cardiac output should be somewhere between 4 and 7 liters per minute. Stroke volume, which is, remember, part of cardiac output, the normal stroke volume is somewhere between 50 and 100 milliliters per beat. Right ventricular and left ventricular ejection is about the same amount of blood. So each ventricle pumps about the same amount of blood with each pump. Determinants of stroke volume include preload, afterload, and contractility. Remember, preload is the volume of blood in the ventricles at the end of diastole, or just before the ventricle contracts. Preload of the right ventricle is measured indirectly by measuring the CVP. Preload of the left ventricle is measured indirectly by looking at the pulmonary artery wedge pressure. And afterload is measured by calculating the systemic vascular resistance and the pulmonary vascular resistance. Again, other things that we can calculate from the pulmonary artery catheter are the cardiac index, which is a more accurate reading than cardiac output because it takes into account the size of the patient. So cardiac index is cardiac output divided by the body mass index. Now, I'm not going to ask you to calculate any of these factors. All of this is done by the computer that the patient is hooked up to. So you can actually just look at the machine and determine these values. So when we shoot a cardiac output, it'll give us the output and the index. Typically in the CVICU, when we're managing a patient, we're actually managing the patient based on the cardiac index versus the cardiac output. Same thing with pulmonary vascular resistance. It's the mean pulmonary artery pressure minus the pulmonary capillary wedge pressure times 80 divided by the cardiac output. You can see those formulas. I'm not going to ask you to memorize those formulas. I'm not going to ask you to calculate, but understand these are values that we can obtain to help us manage our patients more diligently in the ICU. The pulmonary artery catheter works simply because we recognize that our cardiovascular system is a closed system. Now we understand that we lose nutrients, we lose oxygen, and sometimes a little amount of fluid at the capillary beds. This all works because we can measure pressures based on fluids and how waveforms travel through fluids. When we look at our pulmonary artery catheter, it's floated through typically the right internal jugular or through a subclavian vein into the inferior vena cava, then into the right atrium, through the valve into the right ventricle. Now, typically we don't measure here in the right ventricle. There's an opening here that actually will measure this. This measuring our CVP. Basically, then it's threaded through and goes all the way down into the pulmonary arteries. It basically would continue floating it until with the balloon up until we see what's called a wedge pressure. Then the balloon is deflated. So basically, when the balloon is deflated, we're measuring the pressures in this area. Now, when that balloon is inflated, we block everything off here, so there's no flow coming from this direction. So we're measuring pressures on this side of the balloon, which initially is measuring the left atrium and left ventricle of the heart. And so that's why we can get indirect measurements of both of those areas. So remember, when we're measuring left ventricular end diastolic pressure, it's an indirect measurement, not a direct measurement of the left ventricle itself. Now, this is what a pulmonary artery catheter looks like, and I've got some better slides, but basically you can see multiple ports. This is for the thermometer. This is the yellow port, which is usually connected to the transducer to measure the PAP pressures. A white or clear port, which is used to actually give fluids through. Blue port is connected to a transducer to monitor the CVP. The red port here is the balloon port. There is no fluid that goes into the balloon port. Basically, only air goes into that port. They all terminate at different points on this catheter. So this gives you a little bit better look at it. You can look through this. Basically, when the catheter is sitting in the heart, the balloon is down. We only blow the balloon up if we want to measure a wedge pressure. Many places have gone away from doing a wedge pressure simply because of the risks that go along with that. So again, what I want you to be able to recognize, if I'm taking a reading from the blue port, that is a CVP reading. If I'm taking a reading from the yellow port, that's a pulmonary artery pressure reading. The red port is only for air, and it has a specialized syringe that will only deliver 1.5 cc's of air into this device. One thing you don't do is ever change this syringe out and get just a regular syringe from your med room. This will only pull back to 1.5 and will only deliver 1.5. Anytime that we are not using the balloon, don't have the balloon up, this basically needs to be locked off, and there should be no air in the syringe. So the syringe should be taken off, air forced out of it, connected back up, and the stopcock or the slide lock in the locked position. Okay. So here's kind of what the gist of it is. Normally, these pulmonary artery catheters may have 3 or 4 ports and one connection pigtail for measuring temperature, which is we have to measure the temperature to measure the cardiac output. The proximal port, the blue port, is used to measure central venous pressure or right atrial pressure. It's also the injectate port for measurement of cardiac output, and I'll show you that in another slide. When we measure cardiac output, we inject 10 milliliters of solution through there into the right atrium, and basically it calculates the change in temperature of the blood from the solution to the temperature measuring port, and then calculates the output on that. The infusion port can be white, it can be gray. You may actually have a clear and a white, a clear and a gray, a white and a gray. Depends on how many ports are there. But those are typically used for fluid infusions. Many times we want to use those for our different types of pressor agents, or so that we can make sure we're getting the fluids directly into the central circulation. The distal port, the yellow port, is used to measure pulmonary artery pressures, and it's used to measure wedge pressure when the balloon is inflated. Remember, wedge pressure, balloon inflated. The balloon port of the red port is used to inflate the balloon at the end of the catheter that allows the measurement of the wedge pressure. Remember, only air goes into that pressure, and only use a 1.5 cc syringe to inflate the balloon. Never pull a syringe from your med room to blow up that balloon. Okay. So the proximal port is used to measure the central venous pressure we've talked about, and also kind of read the right pressure of the right atrium. Normal value of the CVP, according to your Lippincott book, is 2 to 6 millimeters of mercury. Now, an elevated CVP usually means either fluid volume excess or some type of right ventricular dysfunction. Now, we can also see with elevated CVP, we can actually see it going up with things such as cardiac tamponade, tricuspid valve stenosis or insufficiency, constrictive pericarditis, pulmonary hypertension, or as we talked about, right ventricular infarction. Now, understand the normals I'm giving you are from probably different sources. I looked, most of it's from the Hinkle, but when you go into work someplace, they may have their own values that they use. What I want you to understand is an elevation, what the problem is with an elevation of the CVP, what the problem is with a decreased CVP. Typically, if we're looking at a low CVP, which is measured from the blue port, we're looking at hypovolemia. We're looking at fluid status. That's usually what we're seeing with that measurement on those patients. So remember, CVP really looks at fluid volume on your patient. Fluid volume. Now, the infusion port can be white or gray. Again, it's just an extra line to deliver fluids into the central circulation for your patient. The yellow port is for basically measuring the pulmonary artery pressure. The pulmonary artery pressure. When we look at that pulmonary artery pressure, what we may be looking at is looking at right ventricular function. And as part of that, when we're just looking at the PA pressures, when we're looking at non-wedge pressure. So we're looking at the PA pressure. It basically is looking at the normal pulmonary circulation. The diastolic pressure reflects left ventricular pressures. So really what we're looking at is the pulmonary circulation and the right side of the heart circulation with this. Pulmonary artery pressures range from 15 to 25 millimeter mercury systolic to 8 to 15 millimeters of diastolic. The mean arterial pressure is usually somewhere around 15 millimeters of mercury. And many times what they're monitoring, like in CVICU, is they're looking at that mean pressure. They're trying to maintain that mean pressure kind of in the mid-range there. So if we see changes in the pulmonary artery pressure, that can be increased pulmonary artery pressure, can be from left-sided heart failure. It can be from increased pulmonary blood flow, a left to right shunting with an atrioventricular septal defect. Any condition that might cause increased pulmonary arterial resistance, such as pulmonary hypertension, volume overload, mitral stenosis or ARDS, or even hypoxia, which can cause constriction, can cause these type problems. Now, a decrease in the pulmonary artery pressure typically is related to volume deficit. Again, it's some type of reduction of the circulating blood volume. And really, that's what we're looking at if we see a decrease. Again, nurses and physicians are using these to monitor all that's going on with our patients. Now, we also use that yellow port to measure the wedge pressure. When the balloon is inflated, the catheter wedges in a small section of the pulmonary artery. When that is wedged, it basically is now measuring pressures from the left side of the heart. We're measuring what's called the left ventricular end diastolic pressure. The normal values of this left ventricular end diastolic pressure is somewhere between 4 to 12 millimeters of mercury. We want to measure that as the patient at the very end of expiration of the patient. So they take a deep breath in, they exhale. So just as they end exhalation, that's when we want to look at that reading for that patient. Elevated wedge pressure can indicate left-sided heart failure, mitral stenosis or insufficiency, or pericardial tamponade. Again, low readings usually are related to fluid volume type issues. Now, we talked about measuring the wedge pressure. To measure a wedge pressure, we have to insert air into that red port. Basically, we insert 1.5 milliliters or cc's of air to inflate that balloon. This is where a huge complication can come in with this catheter. That's why many places have gone away from actually looking at a wedge pressure. There's been instances where the nurse, the physician, whoever's doing the measurement did not remove the air from the balloon when they finished doing the wedge pressure, and basically we got necrosis of a part of the lung. The other thing that can happen is if you're having trouble inflating, the catheter may have moved further downstream and you're in a small capillary, and you can actually cause more problems by doing that. So you can actually rupture a capillary bed or pulmonary capillary if you do that. So be very careful when you're doing these. You should only leave up around 15 seconds to get your measurements, and once you do that, take your syringe down. Again, to be on the safe side, once you're finished, take the syringe loose, to discard any air that's in syringe, connect it back up, and make sure that your slide lock or your three-way stopcock is turned off. This particular one has a slide lock up here, you can see, and it's got red lines. When the red lines line up, it's open. You can push air in or take air out. What you want to see basically is the lines being not connected. When it's not connected, it's locked. So typically when in normal situations, the lines should not match up. There should not be any air in here, and there should not be any air in here. That's just a safety type feature that you want to do to make sure there's not any air in there. Now, the other thing that can happen is sometimes when they do a wedge is you take the air out and you don't see a change in the waveform. When you put the air in, you should see a change in the waveform of these patients, and you want to see what's called a wedge waveform. If you let the air out and that wedged waveform continues, then the balloon has moved too far down. So you've got to basically do something to stop that, because of that wedge you can get problems. Typically you're going to turn the patient on their side and see if that makes a difference. Raise the head of the bed. If that doesn't help, then you're going to call the physician and let them come back and pull the catheter back slightly. The temperature pigtail is here. It has a red cap, but when you see it in use, it's just a big, large white thing with the yellow on it. It's plugged into a lead that's coming from the monitor, and it's used to measure the patient's core temperature. And again, we want to measure the core temperature. It's also important as we measure cardiac output for patients. So this is the whole system. When you look at it, basically we've got the pressure bag like we've talked about before. We've got our catheter. It's hooked up going in. Now, all the catheters now have a little sheath over them, and that's to maintain this portion sterile. And the reason we want that is if we have to advance the catheter for some reason or have to pull back, we want to keep that part sterile. Okay? For that, you can see our balloon port, and you can see basically a transducer port here. This is called an introducer, or some places will call it a cordis, and that had to do with a brand name. But basically, this is a large bore introducer device that goes into the superior vena cava or to the right internal jugular. It's a large bore IV, and your Swan-Ganz catheter actually threads down through that to get into the site. Most of these will have some type of device where you can actually give IV fluids through here. In CVICU, this is the port they usually will use to give their pressor agents through to their patients. You can see, here's our Swan-Ganz. You can see that basically we're connected up to our transducers. We remember they're color coded, so blue would be CVP, yellow would be PA pressures. If we had an arterial line, we would have here, and it would be going to the arterial line. All of these are plugged up and are hooked up to the monitor, which gives us our readings. Again, we've got a pressure bag that's delivering normal saline. This should be at 300, and it's delivering saline down to these to keep these open. So the whole part of the monitoring system includes a monitor, a pressure bag, a transducer, and a catheter. So as you look at it, all of this is part of this whole monitoring system. All of those are necessary to actually get a monitoring process on that patient. So here are the components. A bedside monitor. The monitor basically is an amplifier that's right there at the side. It basically takes the signal coming from the transducer, turns it into electrical readouts that we can see. The transducer changes the mechanical energy or the pulses of pressure into electrical energy so it can be given to the machine. Now the transducers must be level with the phlebostatic axis, and you can estimate this line by intersecting lines from the fourth intercostal space and the mid-axillary line. And then some places have a recorder, of course, that's attached to the monitor so that we can actually print out the information. Now here's the phlebostatic axis. You do need to know where the phlebostatic axis is located. You need to know the fourth intercostal space, mid-axillary line. To get an idea, it's usually around nipple line. Again, can only say usually. Your best bet is to count your ribs and count down to that fourth intercostal space. We choose this area because it's typically about the level of the right atrium. And that's where the majority of our measuring is taking place, around that right atrium. If our transducers are too high or too low, we're going to get false readings. So it's every shift is going to level their transducers with that phlebostatic axis. Just like we talked about when we talked about our patients going for a PCI, and we mark their pedal pulses so that we can find them when they come back. It's not a bad idea for the first person that does this to actually mark that area, and then everyone can measure and level to that same area. That way we get consistent readings and we can follow the trends of the readings. Showing here basically doing that. To level, you just take some type of ruler or rod that has a bubble level in it, and you basically will level to the top of your transducers. Your facility will have specific guidelines of which part of the transducer to level to. It may be the bottom, it may be the stopcocks. It doesn't matter. Follow your standard operating procedures and level to where they tell you to level. And then maintain that always. You can take readings with a patient elevated. You can go up to 60 degrees, but you must level that transducer with that phlebostatic axis. Now, insertion of a pulmonary artery catheter, you can see this it's pretty straightforward type process. It's a central line insertion type procedure where everyone around the table is in sterile gowns, masks, and gloves. As a nurse, your responsibility typically is going to be getting the transducers all set up, making sure all those lines are set up and ready to go. Typically, the physician will hand off to you the part of the pulmonary artery catheter that connects to the transducers, and then have you flush through the lines so that we're ensuring that there's no air in the system. Once the physician gets the introducer in place, they'll go ahead and insert. They'll have you check the monitors, make sure the monitor's working. You'll turn those on. They'll start the insertion of the catheter. As they get the catheter in, they're watching for waveforms. You can see the waveforms. Once they get into the right atrium and see these waveforms in the right atrium, they will inflate the balloon. By inflating the balloon, it allows the blood flow to actually help pull the catheter through and direct it in the right directions. So they're watching for the waveforms. Once they enter the right ventricle, you can see the changes in the waveforms. The waveforms gets much larger, so we see a change in the pressure. They continue to monitor it, and then they'll see the change in the waveform. This is right ventricular waveforms. These are pulmonary artery waveforms. So the balloon is up still, so we're watching these, watching it go through, and then once that balloon actually wedges, we'll see the change in the waveforms here. Once it's wedged, they will lock it down, and then they'll deflate the balloon, and then what you should see once they deflate the balloon is a waveform like this again. So you know then you are in the right place. Now these readings listed on the bottom are not the ones that are consistent with your book. Again, that's what I'm telling you when you look at what readings. When you get into your facility, they will have a listing of what they want you to monitor by and where you treat by. So I want you to understand what you're going to do if it's high, what you're going to do if it's low. Okay, so when we get ready to insert this pulmonary artery catheter, you've got to have a consent from the patient, informed consent. You're going to be setting up the pressure system per institution policies. You're going to flush all the ports, establish the phlebistatic axis. You're going to zero the system, and then help that physician. You're going to make sure they can see that monitor as part of that process. Once they're finished, we're going to go ahead and get a chest x-ray on that patient, so that we make sure, because anytime you put in a central line, especially in the subclavian region, there's a chance of creating a pneumothorax. So we want a chest x-ray. Again, we talked about it's inserted into a large vein, usually internal jugular or the subclavian. Depends on what type of surgery they're doing or who's doing it. Threaded through. Once the balloon's inflated, basically we take down the balloon, so we're managing the PA pressures on those patients. Complications, basically the complications are pretty much like any other central line. So you're going to treat this as you would any other central line type process. If you look at chart 14-2 in your Lippincott Hinkle book, MedSurg book, it gives you a big list of things that you need to be aware of when you're looking at these things. Some of the things that can happen, you can have bleed back. Again, if you don't set up your stopcocks correct, you can see a bleed back. I have seen that happen. You can have bleeding at the insertion site. You can develop a pulmonary embolism, an air embolism. You can develop pulmonary infarction, especially if that catheter moves too far downstream or someone leaves the balloon up. You can have a rupture of the pulmonary artery. Again, if it's down too far and we try to blow up the balloon, we can rupture a small pulmonary artery capillary. And then as you're putting it in, because it's going through the right ventricle, it can cause dysrhythmias as part of that process.